Good afternoon, everyone. This is Mary DeCelia with LexisNexis Healthcare, and I will be your moderator for today's event. We're so very glad you could join us today. Our webinar today is Social Determinants of Health, Turning Potential into Actual Value. Before we get started, we have just a couple of housekeeping items. Today's event is being recorded. We will email you a link to the on-demand recording so that you can view the presentation again later or share it with a colleague. This is an interactive event. Our speakers will be taking questions via the chat feature. While all questions will be addressed at the end of the presentation, you're more than welcome to send your questions in now or at any time throughout the webinar. To chat, please click the blue bubble on the bottom left corner of your screen. And lastly, we will have polling questions throughout the presentation, and we'll provide instruction on how to respond at the time of each poll. Now I'd like to introduce our featured speakers. Erin Benson is the Director of Market Planning for LexisNexis. Her focus is on the development and execution of strategic planning for member identity and socioeconomic determinants of health solutions. Prior to joining LexisNexis, Ms. Benson was a senior consultant at Deloitte Consulting. She holds a bachelor's and a master's degree in human and organizational development from Vanderbilt University and an MBA in strategy and management from Duke University, the Fuqua School of Business. Rich Marino is the Director of Strategic Solutions for LexisNexis. His focus is developing and deploying solutions that improve health outcomes, reduce the cost of care, and enable consumerism for health plans and systems. Rich brings over 20 years' experience in data, analytics, and predictive modeling with tenure at such companies as SAS Institute, Ingenix, and MDON. He is a graduate of the University of Illinois at Urbana-Champaign. Erin, we are ready for you to begin.
Great. Thanks, Mary, and welcome, everyone. We at LexisNexis would like to thank you all for taking the time today to consider some new and innovative strategies in achieving your organization's quality and subsequently financial goals. We'd like to extend our thanks to the MCOL professionals for their support in facilitating the sharing of this important content. We hope that today's session will lead to continued conversation, so we'll be sharing our direct contact information at the end. Specifically this afternoon, we want to cover two key objectives. First, we'll examine what is needed to deliver success with social determinants of health. This will include debunking common myths about socioeconomic data and revealing the truth about requiring correlation to health outcomes. We'll also look at previous generations of social determinants of health and what is required for success. Our second objective is we will discuss how social determinants of health innovation can impact quality goals while reducing costs and improving member experience. To do this, we'll look at examples of ways social determinants can enhance predictions as well as impact care coordination. We'll also address the importance of identifying combinations of socioeconomic factors in assessing member risk. A scenario will help bring the discussion to life so you can see how the socioeconomic data can enhance your workflows. Social determinants of health, including information on relatives and associates, assets, trends over time, neighborhood and household characteristics, and more, can be utilized to improve care management and risk stratification activities. And looking at what's occurring in the healthcare market and with various conversations I've had with healthcare organizations across the different verticals, what's clear to me is the value of social determinants is becoming more recognized. But defining what data provides insight into social determinants and how to use it is a lot less clear. So in order to shed more light on this, I want to start by reiterating the importance of social determinants of health in improving health outcomes, but also separate 5 common myths we see about socioeconomic data from the truth. Social determinants of health is certainly a popular topic, as we can see from the attendance today, and with good reason. We're so used to managing our health around social determinants that we aren't even consciously aware of the impacts they have on our health. I know I was surprised to learn that 1 in 3 deaths in the U.S. annually are related to social factors. The impact is clearly significant. We at LexisNexis like to say that social determinants of health are the X factor needed to identify who needs help and how to help them achieve optimal health results. What we mean by this is that what you can learn from claims data alone is not a comprehensive picture of the individual. The environment in which a person lives impacts their likelihood to develop health conditions as well as their likelihood to effectively manage those conditions. Care recommendations need to be a good fit for a member's environment and not just their medical condition. Because if those recommendations won't work within the person's physical environment, they aren't affordable or conveniently located, and they're provided in a way that is hard for the member to understand, they're not going to be effective at improving health. Studies like the ones shown on this slide support that. To achieve the benefits of addressing social determinants of health, it's really important to know what data can provide insights into those determinants. So we'll look at 5 myths and truths about social determinants of health data now. The first of our 5 myths is that socioeconomic data is just more noise in an already data-overloaded world. While it's true that in the age of big data, it's easy to become overwhelmed with the sheer amount and variety of data available on members, socioeconomic data is one of those key pieces of data that really should rise to the top. You've probably seen studies that show that medical care determines only about 20% of overall health, while social, economic, and environmental factors determine 50% of overall health. This means to effectively achieve better health outcomes for members, payers really can't afford to ignore 50% of what determines their members' overall health. In addition to being very valuable data, this socioeconomic data can actually make member risk assessment more efficient and less time-consuming. Innovative payers we're seeing are already determining ways to incorporate this data into their predictive modeling and care management programs. With social determinants of health data, payers can design better care management programs to meet the needs of their members. This means more accurately identifying high-risk members can help payers to become more effective and efficient by allocating limited resources to support the members most in need. Our second myth is that all data about a person and their life outside of their medical claims relates to their social determinants of health. The truth is that while data may be useful in some capacity, not every piece of data on a person is a social determinant of health. There are endless ways, as I'm sure you know, of receiving data on individuals, including basic demographic data, survey data, marketing data, and more. But a lot of it has really limited potential for improving predictive accuracy or identifying hidden risks. The key to addressing social determinants is to identify a source of data that's continually updated, provided in a consistent format based on reliable sources such as public records, and contains data that's been clinically validated to predict healthcare outcomes. Rich will talk about that more with us soon. Clinically validating attributes is critical to successful predictive analytics because some attributes don't correlate strongly to health outcomes. That really is where you're seeing the noise. In an analysis of over 560 attributes by our data science team, 442 were found to correlate with key health outcomes like readmission, medication adherence, hospitalizations, and overall health costs. And even when attributes are clinically validated, we've found that different attributes correlate to different outcomes with different accuracy strengths. So knowing correlations allows you to use data to enhance predictive power so you can improve risk stratification efforts. The third myth I hear is that examining only individual socioeconomic attributes about a person will allow you to make accurate predictions about a member's overall health risk. The truth is, focusing on an individual's attributes rather than the combined picture is really misleading. I like to think of the analogy that it would be like eating a cake, where you eat the individual ingredients of a cake and expect them to taste the same as the cake itself. The results are very different. When you're predicting risk and personalizing care management, it's crucial to view a person holistically across multiple categories of social determinants, which range from social and community context to neighborhood and built environment and education and more. Any attribute on its own is helpful, but not enough to develop an accurate risk understanding because you really want to look at the complete picture about an individual. For example, it's commonly known that low income can correlate with poorer health outcomes. However, the additional knowledge that the member is in college may indicate that the low income is temporary. That member may actually end up being more likely to attain a better health outcome because education often leads to better career opportunities and a higher future income. The fourth myth is the one that I hear the most often, and that is that aggregated data at the zip code or census level can be used to personalize care for a member. For market expansion and resource allocation decisions, looking at aggregated level can be useful. But for personalizing care management, hundreds of attributes need to be considered when determining an individual's health risk. Within a single zip code, it's not unusual to see variance in income levels, crime rates, and other factors impacting an individual's neighborhood and built environment. If I think about the city where I live in Atlanta, you see a lot of change if you just walk a few blocks over. This is why it's important to look at an individual's specific address. Further, focusing on zip code alone ignores the influences of education, economic stability, and social and community context. So if I go back to my previous cake analogy, it's only one of many ingredients you'd need to bake a cake. Getting data across various categories of social determinants at the individual member level allows care providers to see that comprehensive view of a member and create a more comprehensive plan of care outreach. And then finally, our fifth of the myths, and our final one, is that we will discuss that socioeconomic data is only useful in combination with clinical data. The truth is that adding socioeconomic data to clinical data can help payers to personalize care and more accurately predict risk. But even in the absence of that clinical data, using only socioeconomic data has proven to be useful. In fact, it can more accurately predict risk based on total cost than traditional age and gender predictions alone. And we've shown that it can improve the accuracy of predicting readmission likelihood, even compared to certain clinical data models. Even small lifts of 1% or 2% in accuracy over traditional predictions can lead to really big impacts. So using socioeconomic scores to more accurately identify high-risk members who account for the majority of healthcare costs and then proactively address their care can lead to 10 to 20% savings over using traditional predictive models alone. I hope that the key takeaway you have from listening to these myths is that socioeconomic data is a vital force for healthcare risk prediction and the improvement of care management, but it's got to be the right data. So based on these myths we've just discussed, we have a polling question for you.
Our first polling question: which myth about social determinants of health was the most surprising to you? Social determinants of health data is just more noise. All the data about a person determines health outcomes. Standalone attributes allow for accurate predictions. Aggregated data can be used to personalize care. Or social determinants of health data is only useful with clinical data. I'll give everyone about 30 seconds to enter their response. A few more seconds. They're still coming in. That's great. And let's look at our results. Erin and Rich, what do you think?
Thanks, Mary. So it looks like we're actually pretty evenly split among the first four, but then see a real uptick towards the end with social determinants only being useful with clinical data. I think it has been surprising even to us to find how predictive social determinants on their own can be and how it can stand up even when compared to clinical models, but it just goes to show how much of an impact it really has on overall health outcomes. Rich, I'll turn it over to you to talk through our next section on how to use it to be successful.
Thanks, Erin. So now that we've examined the myths surrounding social determinants of health, let's dig into the pitfalls that our industry has encountered so far and what is needed to overcome those previous challenges and successfully generate positive outcomes and value. The first phrase, I guess I should say, while the phrase social determinants of health is in vogue currently, if you boil it down to attempts to marry claims enrollment data with outside member intelligence, that's actually been going on for some time. First generation of this was focused on community data, which Erin alluded to previously, which could provide some insight around a member's neighborhood and community. The problem is that it completely missed all the other categories of social determinants of health, which really require member-level information. Additionally, as Erin also alluded to, while some neighborhoods are homogeneous and assumptions can be inferred, other neighborhoods, oftentimes in urban areas, have luxury condos and Section 8 housing literally next door to each other. This makes drawing any useful information out of them challenging at the least. The second generation attempted to overcome this by evaluating data sources that could provide member-level detail, but that really weren't built for any healthcare use cases. These were often data sets from marketing companies or strictly consumer data companies as well as a few other sources. And while they're excellent for their original use case that they were built for, their match and fill rate tend to fluctuate widely. This lends it very difficult to analytics people trying to build models. Additionally, they're often seen as data dumps that require analytics teams to reverse that 80-20 rule and spend an inordinate amount of time simply examining the data and deciding which, if any at all, attributes could be used for modeling. So if we're going to cross the chasm and from an interesting idea to actually delivering value, the first step will be working with a data set that addresses all the categories of social determinants of health and provides member-level detail. So if anything the early attempts at generating value from social determinants of health has taught us, it's two critical lessons. One, data to be used in any social determinant of health exercise must meet the criteria established on this slide. Data sources have to come from multiple different areas, inclusive of marketing, public records, credit and consumer data that can paint a comprehensive picture of your members. The data elements need to cover all 5 categories of social determinants of health data: your economic stability, education, health and healthcare, neighborhood and built environment, and social and community context. Again, the information and sources should be able to be supplied at the member level. And it's not just important that it attaches to the member, but that member should also have associations. So if you're trying to determine whether or not a member might be socially isolated, you really also need that detailed to be associated with their close associates and relatives. Then finally, we want to reverse the 80-20 rule. We want, if we're working as an industry to overcome these problems, we don't want any more data dumps. We want the data to already have been proven to be highly correlated to health risk, so we can begin building our models right away and not spend 80% of the time on data prep. That's what's needed for us to go ahead and cross the chasm. Now before you see all 5 categories of social determinants of health, and I want to spend a moment talking about these because what we've articulated here so far is it's critical that you get data that spans all 5 categories. So here's some example information that can be gleaned from these different categories. As a reminder, as Aaron alluded to earlier, you don't want to look only at this one ingredient per case. You want to aggregate them in total to get a better picture. But if we do look at these individual ingredients and how we bake that cake, an example under economic stability might be address stability. There's a high correlation between members with a high number of addresses in the last 60 months and the use of the emergency room. Now, this makes sense actually, because if you're more worried about having a roof over your head, you're probably not focused on your health or probably don't have the financial resources to visit a primary care physician. We've also seen under economic stability professional licenses being something quite valuable. Members who have family members with a professional license, anything from lawyers to plumbers, are more likely to finish an intervention program and stay motivated, as research has shown. If we move over to education, it's critical that we have an understanding of the level of education of the people we're engaging with to make sure that our communication with them is written or scripted at the appropriate level. Health and healthcare is quite obvious. Do they have access to care where they live? Neighborhood built environment. Do they live in a high crime neighborhood, which would make exercise outside an impossible feat in an intervention program? Another aspect is whether or not they're taking a look at their income index. For instance, has their income precipitously fallen recently, indicating that they could be under stress, which exacerbates comorbidities. And finally, if we look at social and community context, we could glean information such as crimes. You could look at parent and guardian and see if they've been involved in any crimes previously to try and make predictions around adverse child experiences that might lead to future negative outcomes. We also see a strong correlation between registered voters and people being motivated to participate in an intervention program to its completion. We'll now move to our second polling question.
Thanks, Rich. Our second polling question: which of the following social determinants of health would be the easiest for your organization to address based on current care programs? Economic stability, education, neighborhood and built environment, social and community context, or none of the above? We'll give everyone about 30 seconds to register a response. Just a few more seconds. And let's see what our results are. Rich and Aaron.
Thanks, Mary. So it looks like education is towards the top, and that really makes sense that we're seeing a lot of community outreach happening where there's trying to do more education in the community around different health preventative programs and really just educating the community on what types of health is available. Social and community context is an interesting one too, Rich. I think, I don't know what your thoughts are on that, but support groups I would think would be a pretty common thing already available.
Yeah, we're definitely, with the projects we've been involved with, Aaron, we're definitely seeing the ability, I guess, excitement about the ability to identify whether or not these might represent health barriers and the readily available resources that be brought in to address them. So there's some excitement about whether or not we could identify a health risk that could be solved through social and community context attributes.
I agree. So you know what I think is interesting about this is that last category actually got the most votes for none of the above. And that actually leads us well into our next section. So Rich, when you walked us through the different generations of social determinants of health data, it made me start thinking about the different generations of questions that I've received in the market over the years. So when I first started working on socioeconomic solutions, the most common question that I was asked was, why is social determinants of health data important? But today, the most common question I'm asked is, how do I incorporate social determinants of health into the workflows? How do I achieve that value? And I think that speaks to that last poll question where people aren't really quite sure yet how to integrate it into their flows. So hopefully we can give them some ideas. The most common way of utilizing social determinants of health data so far has been to incorporate it into existing claims-based predictive models to improve predictive accuracy or to use it to create new predictive models. Our data scientists have found hundreds of correlations between socioeconomic health attributes and actual health outcomes like total cost, hospitalizations, medication adherence, and emergency visits. So this is a valuable and viable use of the data. And this is where it fits most easily within existing workflows. But the second use is for care management purposes, and this is where social determinants of health can be truly transformational. We recommend as a best practice to use social determinants of health not only to build those predictive models related to health outcomes, but also to build models that identify health barriers. These barriers can include determinants such as social isolation, which can be predicted based on attributes related to proximity to nearest relatives and associates, marital status, number of people in the household, and more. You know, I found it interesting that earlier this year there were news stories that the UK had appointed a minister for loneliness. And it sounds like a strange title and such a unique concept that it was largely mocked in the news. But the reality is that social isolation and loneliness are correlated to negative health outcomes, putting the individual at greater risk of cardiovascular disease, dementia, depression, and anxiety as examples. But imagine the impact that could be had if you could identify who was likely to have that social isolation and get those individuals into support groups or arrange for more frequent follow-up calls. Other areas of barriers include educational disparities, high poverty rates, neighborhood safety concerns, and there are many more. Information on education can provide insights into low health literacy levels and incomplete perceptions of health, which may indicate the need for more education or differently designed education, like providing videos to help members know how to take care of their own health. High poverty rates may indicate the need for financial assistance. Neighborhood safety concerns, which, as you mentioned before, can lead individuals to not exercise because they're afraid of being outside, but this can worsen obesity and other conditions, so it may mean that we need to find other ways for them to safely exercise. These four listed on the slide are just the start of different social determinants of health barriers that may exist for an individual member that could be determined and addressed using socioeconomic insights and modeling. So by using the data to build models that predict the likelihood of different health outcomes occurring, payers can prioritize members for care based on their needs. Then, by building models that identify health barriers based on those social determinants, payers can also inform clinical care operations about the types of interventions that will be needed to improve health outcomes. In doing this, everyone wins because member health improves. Let's go through two examples of correlations. At LexisNexis, we're able to identify how close a member's nearest relative or associate lives to them. So we define associate as someone that you have lived with or shared an asset with, as an example. And this is important because it provides insight into social and community context of members. So our data scientists found that members who have relatives or associates that live less than 25 miles away are more likely to adhere to their medications. There was a drop-off when the nearest relative was more than 25 miles away. So knowing this, more education could be provided to the member on their medications, or programs could be put in place to have those medications delivered to their homes on a regular basis to improve adherence. Another example is related to economic stability. So here, our data scientists found a correlation between readmission to the hospital within 30 days of an inpatient hospital stay and the sum of tax-assessed values for all properties that the member currently owns. The correlation showed that individuals of the same age who have higher average property values are less likely to be readmitted to the hospital within 30 days than those who have lower average property values. These are just two examples among hundreds of ways that socioeconomic data can provide important insights for predictive analytics. Rich, I'm going to turn it over to you to speak more about how understanding social determinants about an individual can also be used to tailor their care and achieve value.
Great. Thanks again, Erin. I'll go ahead and forward the slide right here. So we're now going to talk about utilizing social determinants of health to generate value. And this brings us to the second critical learning that Erin and I have been speaking about. To generate value, you need to deploy not just models that improve or provide lift on risk stratification, but also models that identify the health barriers that, unaddressed, would lead to missed opportunities to improve a member's health. In order to kind of paint this picture, we're going to talk about a story about Larry and Bill. Now, Larry and Bill are two fictional members of your plan. They're both 67 years old. They both live in a rural area. They both recently re-enrolled. And based off claims information, we know that they are pre-diabetic and have COPD. Based on what we see here from claims enrollment information alone, it would cause us or lead us to believe that we could treat them in the same manner and probably involve them in the same intervention program. But as we've been alluding to, there's a lot of insight that can be gained by asking social determinants of health questions, or better yet, building models which will identify social determinants of health. So if we surround these two people and try and learn not just their clinical information, but information about their neighborhood, about their access to health, their economic stability, their education and social community context, we could learn a dramatically different picture. As you can see here, our first lesson that we had is we need to make sure we have member-level data that addresses all 5 categories of social determinants of health, right? So if we now have data sources that allow us to ask questions, we get very interesting answers yet, which could be aggregated and inform us on what we need to do to take care of Larry and Bill. For instance, if we look at Larry and we start at 12 o'clock, he lives nowhere near any in-network primary care physicians or hospitals. His income the last 2 years has been quite small. He never made it past high school, and no one in his family had either. So that tells us about what we need to communicate to him at what level. Unfortunately, if we keep moving to about 7 o'clock, we see that he lives alone, and even if his family, his family wouldn't have to be communicated at a proper level, but also they don't live with him. So there's no one that we can count on to possibly be a caregiver and assist in his protocols. And then finally, it's difficult for Larry to get out and exercise because he lives in a high-crime neighborhood which is unfit for outdoor exercise. And this is quite stark contrast to Bill. Bill lives within 10 miles of the in-network hospitals and primary care physicians. Looks like he's still employed and employed generously for the amount of money he makes. He holds a postgraduate degree, and every member of his family has had a 4-year degree. And he lives with his spouse and has 5 first-degree relatives within 10 miles. Finally, he lives in a safe neighborhood according to Crime Index, and there's no vacant homes in his neighborhood as well. We can learn a lot from that information, and the first thing we learn is that Larry has significantly more risk than we would have thought based off of claims-only based analytics. Conversely, Bill is much less riskier than we initially assessed based off of claims information. So how do we make use of this? Now, how do we operationalize this new learning? Well, this is the point where really innovation needs to occur. I'll call it a 3-step three-step process into what we want to model, right? The first thing we suggest is deploying a new predictive model based on social determinants of health, which identifies health barriers from data sources across all 5 social determinants of health categories. The second step is to build our risk stratification models, which we know will segment our population and that top 5% that accumulate costs for 50% of our medical expenses that typically are chronic or at-risk conditions. The third step is we want to crosswalk those two, and we want to supply that information to our care management team so it's at their fingertips at the first point of communication. So in our previous example, based on claims only before we did this new innovative modeling exercise, we would assume that Larry and Bill both would have entered and involved in our care management operations at the same point. From left to right, you could see a sample severity index that a care management team might be utilizing to figure out where they would intervene and what type of program they would include Larry and Bill. And based on claims-only information, we'd probably go ahead and have either a letter or a phone call from a nurse or clinical care manager reach out to them and encourage them to have a health risk assessment. However, based on the new information that we've learned from utilizing social determinants of health information, we really realize that these two are coming in at vastly different points in the spectrum, and that with Bill, we could probably get by with a significantly less touch. So perhaps mailing a postcard monthly reminding him to take his weight, inviting him to participate in a wellness program might be appropriate. Versus Larry, we see he's all the way over at the severe risk category, which will require significantly different path for us to try and prevent those negative impact on his health outcomes as well as high-touch, high-risk incidents. Examples of that might be that we, first of all, try and reach out and see what social services are available to him in his community. A good example of this might be whether or not we could leverage village or township resources or religious services or disease-specific programs. We might be able to arrange local transportation for him from those village or township resources, and if not, taxis, Lyft, and Ubers could be arranged. If we take a look at neighborhood and built environment examples that care management might be able to leverage for the severe case, we could coordinate with Meals on Wheels or investigate food delivery programs if they live in a food desert or don't have access to transportation on their own. Also, exercise can be arranged at the local YMCA or park district programs if they're available, or if need be, by sending a physical therapist right into their home. And health and healthcare, we can arrange for medication delivery for those who lack transportation or are immobile and try and involve them in discount programs for expensive drugs. Also, for members who don't live near in-network providers, we can examine the network near them and see if it makes sense to add some primary care physicians or facilities into our network. From an education standpoint, it's critical that we have materials written at multiple education levels, or we could reach out to a phone to explain things and different options to them. And finally, both the phone outreach and the materials probably need to be written in multiple languages. Then finally, from an economic stability standpoint, in this particular example, Larry and Bill probably are retired at the retirement age. So rather than try and find them jobs, we could see, is Larry a veteran, and will he have resources available to him due to that? Can we get Larry on Medicaid? And if Larry is already on Medicaid, can we move him from TANF to SSI? And from a housing standpoint, based on the health barriers we uncovered in previously, we know that if we leave Larry in his current predicament, it's probably not going to lead to a beneficial outcome. So we can see about moving him out there. Is there Section 8 housing available? Will Medicaid have any availability to assist us with assisted living? If we know Larry's health barriers at the very beginning, we can begin right away to mitigate his severe health risk. So with that, I think it's time for our next polling question.
Thanks, Rich. Our final polling question: where will or did your organization first integrate social determinants of health into the workflow? Enhance predictive analytics or risk stratification, improve care management and wellness programs, utilized to make decisions about expanding into new geographies, or other. You're still deciding that first step to take. And again, we'll give everyone about 30 seconds to register their response. And let's see what our results are. What do you think, Erin and Rich?
So obviously overwhelming on the care management and wellness side, which is great because we've seen a lot on the predictive analytics side, so I'm excited to see that so many people see potential there. Rich, anything that stands out for you?
Yeah, Erin, thanks. I think this tells a really good story, too. If we look at the first two rows here, predictive analytics, then care management. I think what it is if people understand analytically, there's probably models that can be deployed that find new insights for them. But where they're focused, or I guess, that's what we take for granted. But in order to operationalize this, in order to truly receive value, it appears that people realize that has to come through the care management and wellness programs. And that's why it's probably driving the largest chunk of the audience response.
That's a good point. If we had one more poll question we'd thrown in here, I would love to know if that's more at the individual or community level, because I think what we're starting to see is these different organizations driving it from community level care and wellness programs down to that individual level. All right. So we really hope that going through these examples and talking through different barriers to health and what could be identified through socioeconomic insights has given you ideas on just the very many ways that social determinants of health can be integrated into your organization's workflows to produce value. It's certainly not any one point. It can actually help throughout the entire member journey. So based on the poll results, we're definitely seeing that you're well on your way, and hopefully for those of you that are still deciding, you've got some more ideas. Utilizing insights on social determinants of health, payers can more accurately surface members that require action and provide better care management by incorporating social determinants of health information. That's probably the key takeaway from today. But the additional benefits is that this then allows for better financial outcomes for your organization too. It can help to reduce claims expenses by improving health outcomes. And then for those of you that are impacted by these, it can also lead to medical loss ratio optimization. Then the ultimate benefit is that payers can retain more customers because the members are more satisfied because they're getting better care, and they're also seeing curtailing rising medical expenses. So there are benefits for everyone involved, from the organizations to the members. So to summarize our session, and then we'll open up to questions, we've explored how social determinants impact health and debunked 5 of the key myths about socioeconomic data. We've also talked about the key criteria for finding successful data to gain insights. We've provided ideas on getting started or furthering existing efforts around incorporating social determinants of health insights into the workflows, especially related to improving care management with our Larry and Bill example. And that finally leads us to our question and answer session. So Mary, I'm going to turn it over to you.
Thanks, Erin. We did get in a few questions. Please do not hesitate to continue to submit questions using the Q&A box. We'll respond to as many as possible. So our first question, in public health disciplines such as epidemiology, incorporation of social determinants of health has been a core approach to understanding health outcomes for decades. Can you speak as to why this concept is just now being adopted by the payer community and what barriers to adoption still exist?
Erin, do you want me to start with that one, or you want to?
Go right ahead, Rich.
Okay. An interesting question in regards to, and it just disappeared. So I'll have to do it from memory, and my apologies. Why is it perceived that the payer might be a laggard? Well, there's a couple reasons. I don't know necessarily I want to call them a laggard. I meant to think that your example might be an early adopter. The first thing that's driving an intense focus on social determinants of health right now, frankly, is medical trend. Health plans are under a lot of scrutiny these days for the year-over-year increase in medical costs. That, frankly, we've been saying this for a long time, but it's starting to become unsustainable. So I think there is an active interest in investigating anything they can which will inform them of opportunities to improve health members' their health outcomes and reduce overall costs. Part of that is the adoption of preventative medicine that you see widely being utilized, and part of it is an expense in analytics to try and determine before an adverse event happens, how it could be prevented. I think there's probably, as science goes, there's a lot that's already accomplished in only looking at claims information. It's been, I think for several years, health plans have been trying to look at outside sources to bring them additional insights and lift social determinants of health, if you will, early stages. But it's only been recently that they started to realize that there is enough good data out there from the right sources that will truly be transformative. I think they played with this and hadn't got the experience they want based off of the failures that we showed you early in social determinants of health. Erin, I don't know if you have anything to add to that.
No, I think that's a great point, Rich. And actually, we get questions a lot about how do you collect this data and how do you make sure that it's reliable. We see a lot of groups trying to make use, as we've talked before, about marketing data or trying to survey members. And the challenge with surveying members is, I mean, I don't know about you, but when I fill out health surveys, I don't necessarily think it's any of their business when I'm filling some of this out, so I'm not thorough in my responses because obviously I understand the correlation to social determinants, but the average individual might not. So we start to look at public records data, which can provide that insight in a really reliable way, and it can be provided in a standardized format. So I think that will help to address some of those problems that we've seen so far and is what is helping payers to be able to make use of this data.
I know it makes us all cringe when we talk about things like this, but if you remember the TV show House about the eccentric medical doctor, his dictum, everyone lies. And oftentimes that's what we see in self-reported information.
Exactly, and I don't even think it's necessarily intentional. It's just they're hurrying through forms when you're, sitting there trying to get something done. So it's I'm a lot more careful with my tax returns and things like that.
Great, thanks, Rich and Erin. We have a few more questions. In the 10 to 20% more accurate risk prediction, is that over age gender models?
Yeah, so that's a good question. So it's actually 10 to 20% more cost savings over age gender models by getting more of the right people into the high-risk programs. So if you think about it, I think like 85% of the costs are driven by the top 5% of your member population. And so if you can get more of those individuals identified in advance and get them into care management, then you are providing care management to those individuals that need it most, and that's going to lead to higher cost savings.
Great, thanks, Erin. Our next question, a lot of data is available at the household level. How does that compare to individual level data for health prediction?
So I'll take first stab at this, Erin, and then you could jump on in. I don't think you want to sit there and say that one is better than the other. I think what we want to say is that you need both. For instance, you could see at the member level what their income is, but then also take a look at the household level income as a whole. At the household, you can see how many people live there, what type of dwelling it is, whether there's any seniors that live in there, age 64 or older, or age 80 or older. You want to combine all those into the models you build to try and determine health barriers. So I think both are valuable, but in and of itself, if you only had household, you'd be missing a big chunk of the picture without having that specific member level detail.
Yeah, I absolutely agree. And we even expand it to say that it's important to understand the relatives and an associate situation because obviously that makes up your social network and has a big impact on your life. So we try to provide that holistic view not only of the member and their individual aspects that are impacting their health, but also the people around them, either in their household or with relatives. But at the end of the day, really getting down to that member level is what helps you to personalize the care because that member, even if they're in a household, might have a different education, they might come from a different background. And so having that holistic picture is really what's going to help you to personalize that care.
Great. Another question in, what are the recommendations for small rural providers that do not have the resources to support care management teams or health coaches to address social determinants of health with their patients?
Yeah, that's a really good question. And Rich, I'll let you speak to this, But what I'm seeing is different groups making more use of like telehealth options and the internet to connect them with different support groups when they're maybe not able to have them in their own communities. But they also don't have to be these large orchestrated programs. You can get them involved in, regular community programs that might be available as well. So it's really just about identifying what their need is and then figuring out within those situations the best way to address it. But I think definitely in the age of electronics, we have a lot more ability to connect people.
Yeah, that's an excellent point, Erin. I would sit there and say it's rather than focusing on the world of opportunity, if you have more resources, to focus on what resources you have and tailor your analytics to that. So if you have a lot fewer, let's say you're an integrated facility or integrated health plan system in a rural area, right? Take a look at what you do have available that you can incorporate and how you could leverage those, and perhaps build models associated specifically with the programs and find people who you think would be successful in that. The other approach might be that if you don't have a lot of analytical resources, to rather than buy the attributes themselves, buy models built on the attributes. For instance, trying without making this commercial, we have ones around readmission and ones on total cost predictions, right? That you could utilize that might be simpler for your, any staff you have to make use of if you don't have a big and large analytical team or if you don't have a big and large care management division.
Yeah, that's a great point.
Excellent. We still have questions coming in. We have about 10 more minutes left to address questions. One question on slide 15 in the economic stability column. Can you please describe liens in more detail?
Yeah, Erin, you want to take that or you want to take that?
Yeah, I can speak to it. So, basically liens, really what it's talking about is, possession of property. And the idea here being that if you have a lien on your house, then you have a situation where you may not have the housing stability. And if you're trying to take care of your medical conditions, but you're also wondering if you're going to have a constant place to live, you may not be focused as much on those health conditions and a lot more on just trying to sort of get by and make sure that you continue to have housing. So that's really what that speaks to with the economic stability piece.
Thanks, Erin. In care management programs, especially those that send a care manager to the patient house and can provide a true assessment of the living situation, are payers looking more into these type of programs? Any comments about that?
Yeah, I'll start with that one. I don't know what the growth trajectory is for that, but I do know several clients that do have these types of services. For instance, I have a client that focuses on duals, and they do send nurses going door to door on these particular identified people, and try and make those individual house visits. I don't know if that's the wave of the future. I suspect there'll always be a certain segment of care management that does that. I do see a wider use of telehealth and more electronic to try and reach more populations at a lower cost, probably being more readily adopted, I should say.
Thanks, Rich. Let's see. Oh, so many to pick from here. Major tertiary care health centers are concerned primarily with increasing referrals from distance and not serving the community around them. How can they possibly investigate social determinants of health of all these patients coming from multiple faraway communities? Is there anything that we can say to enlighten upon that?
Yeah, so I think that's exactly the point that we're really getting at is it's great to look at the community, but a lot of times that tends to be aggregated data about really sort of the neighborhood and some of the key demographics, and it's not getting at that individual level. But if you've got patients coming from multiple faraway communities, the nice thing with public records is that you can still pull social determinants insights about that individual. So at that point, then you're treating the individuals instead of trying to create the overall group. There's certainly places for both types of programs, but with the increase in value-based care and the focus on quality, really getting down to that individual level is going to be critical. So I think that could help with that.
The only thing I would add is if in any way they're getting involved in alternative contracts where they might know a certain level of patients who might be coming to them ahead of time, that opens up the door for more prospective analytics that could be ready for when you have encounters with those patients. So that might be something to look into as well.
That's a good point. And I just looked at the last part again, but how do they possibly investigate all of these? I think with large volume, we've talked a lot today about the power of the attributes around social determinants, but there's also the ability to narrow those down to just key risk scores so that you can quickly risk stratify and don't necessarily have to pull all that information to be able to do that. And we provide that view as well, which can provide care providers with a really quick view of how to risk stratify a population and where their risk might be related to social determinants.
Thank you, Erin and Rich. Have you focused any research on resiliency factors given social determinants of health?
Erin, I don't have an answer for that one. That's an excellent question. I'd have to go ahead and research it. Do you have anything on that?
Yeah, I'd need to understand a little bit more about the resiliency factors. So maybe, Mary, we can follow up with them afterward if you can send some more information about what you're looking for.
Absolutely. We will follow up afterwards on that one. We have another question. As a large medical group who receives patient data via health plans, most to all of this info is not available. What would be first steps to gathering this data to community and then feeding that data back into our data warehouse so it can be analyzed? And that's a long one. I'll leave that up there so you can read it.
No worries. So I'll start, Erin. It seems like most of the information you're not getting in the transfer when you're getting the enrollees or people who will be participating in your program. You just know that who their insurer is. Probably the first step then is to seek out those data sources. And typically what will be needed is a few data elements about those individuals to be sent to your data source provider, and they could then match the information back and send it on back. Now, how you make use of it would be the next question. We tend to talk about utilizing all these different attributes to build models to identify health barriers. That's something that if your group has the capacity to do itself, I would immediately do and have that surfaced and have indicators, so that if it's Rich Marino that come into your medical group and you have done some modeling on me, the model will result that, hey, as you're discussing treatment paths with Rich, be aware that he has some significant health barriers. So ask him questions about whether he needs transportation or whether he could afford drugs and so forth. Erin, I don't know if you want to add anything to that.
No, I think that's great.
Great, thanks. We have just a couple more minutes left before the top of the hour. We have one more kind of long one, so I'm going to leave it up there for you to read with me. Great presentation. Can you comment about the technical work required to bring these data into the analytics engine side, but also how to place it strategically into workflow so a care manager knows key details on each patient? What is the role of the EHR in enabling or preventing this level of integration? I know that's a long one.
It's a long one, but it's a great question. So the way that, and I can only really speak to how our data would be ingested, but the way that we provide our data is system agnostic. So you can load it into a lot of your modeling tools if you want to use it on the analytics side, and we provide it in a consistent format and standardized each time, so we would work with you on the layout. But then ideally what would happen is either the analytics groups would take those attributes and use that to create different risk drivers or different potential outcomes or alerts or scores that could be provided to the care providers or the care managers so that they have just really kind of the summarized level of information that they need on social determinants of health. The other option is that, as I mentioned before, there are also kind of prefab scores that will do things like tell you how much risk a person has over the next 12 months based on predicted total costs, or how likely they are to get readmitted to the hospital within 30 days based on predicted readmission rates. And then using that type of information, you can start to do the risk stratification. So there's definitely different ways that it can be used. The attributes and kind of their raw form can be provided to analytics groups to bring into the modeling, and then from that modeling can come scores and alerts that can be surfaced through EHRs. We're actually starting to see a lot more population health management tools that have specifically social determinants of health pages on them that will do things even like saying this person has a transportation need, so let's go ahead and order them an Uber for their next appointment. So I think you're going to start to see within the EHRs and population health tools a lot more of that connection between social determinants of health and community resources.
Thank you, Erin. We're just about at the top of the hour, so we have one more question we can take. If you've submitted questions and we've been unable to address them during the event, we will address them via email after the event, as all questions are being captured. Our final question: social determinants of health are commonly used in those black box predictive models. Are there any concerns on the demanding or explaining of consumer data?
I'm not entirely sure I understand this question unless it's speaking to explaining why we're using consumer data in those models. And I think that goes with one of the other unanswered questions. So I'll just speak to that, and if I'm misunderstanding the question, then please feel free to send it to us again. But yeah, basically it is kind of unusual to think about consumer data relating to the healthcare outcomes, and that's why we've done so many of the clinical validations. So we showed a couple of the graphs in here that show the correlations between social determinants and health outcomes. We've done that for, like I said, over 400 different attributes related to different health outcomes like hospitalizations, ER visits, and so forth. And so by showing those connections, that's how we start to really help people understand why that consumer data is important.
I'll tackle the first half of the question, Erin. In regards to black box, we do have some clients who are utilizing, black box or artificial intelligence neural network, whatever you might want to call it, to try and choose elements to be built into the model. But we have others which are simply using a decision tree, which might filter out what they think the best attributes are, or frankly, just hunting and pecking and building their own hypothesis and testing it with various different attributes. So that it runs the gamut, and that's an area where, with the right conversation and the right vendor, hopefully some experience can be lent to point you in the right direction and share with you where we've already seen some successes.
Great. Thank you, Erin and Rich. We're 1 minute past the hour, so our time is up for today. We do have some questions that we will follow up afterwards via email. We want to thank all of our participants for joining us today. You will receive a post-event feedback survey via email before the close of business today. We'd love to receive any feedback you'd like to share. Thank you, and this now concludes our webinar.